And I hope you enjoy this. I think people are intimidated about reading legislation. I'd like you to feel comfortable, and I'm going to show you some actual language. And we're going to look at these topics. As I said, a really true single-payer bill will have a provision that says, insurance companies, you're done on such and such a date. You can cover stuff that's not covered, but you're not covering anything that is covered after a certain date. I want to talk about the definition of institutional and individual providers. I want to talk about budgets for institutional providers and fee schedules for individual providers. And again, I want to show you actual language from several bills. And then I want to compare Pramilla's bill and Bernie's bill on how they're going to set rates for providers. Pramilla's bill doesn't say you got to cut provider rates to Medicare levels. She only says when the Secretary of Health and Human Services begins negotiating the first couple of years with doctors and hospitals, use the Medicare rates as a guideline. That's what she says. It doesn't say reduce rates to Medicare levels. So here we go. Here's John's bill. On or after the day the Minnesota Health Plan becomes operational, a health plan may not be sold in Minnesota for services provided by the Minnesota Health Plan. Now I wrote health plan there because I want to call your attention to the slight difference when you get to Bernie's and Pramilla's bills. They use the same language. Bernie and Pramila use the identical language. Prohibition against duplicating coverage. On date X, you see two nouns here. A private health insurer has got to knock it off, and an employer can't offer coverage to their employees. Let me see if I got, yes, let me go to HR 676. HR 676 had a very simple ban. Unlawful for a private health insurer to duplicate. Now come back and look at John's bill. He talks only about health plans and he doesn't say anything about employers. I bet some of you know why.
Scare everybody.
A federal bill called ERISA.
Oh.
The Employee Retirement Income Security Act, passed in 1974 at the federal level, says states cannot impose upon employers requirements that make it hard for multi-state employers, Fortune 500 companies, to create uniform pension plans and uniform health insurance plans for their employees. So you can see the problem. If Arkansas doesn't require maternity coverage, but Minnesota does, and you are ExxonMobil or 3M, your job is a little harder. That was the rationale for ERISA, the Employee Retirement Income Security Act. It's a mess of a bill, and the Supreme Court, it's like trying to imagine the sound of one hand clapping to talk about how the Supreme Court has interpreted ERISA. But pretty much everybody says if John had written into the Minnesota bill what you see here in HR 1384 and S8, an employer has to stop doing that, that would probably be a violation of ERISA. But we think, and we've talked for years, we actually talked to Skip Humphrey when he was AG about this, and single-payer advocates in Ohio in the 90s approached their AG about this. What we're told, and I think it's correct, is you're fine at the state level if you say what John has said, which is you're only going to tell the health plans what they can and cannot do. We're not going to tell 3M what they can and cannot do. But who in their right mind, as 3M, is going to say, oh, God, we enjoy paying $10,000, $12,000 a year for each employee's insurance. Let's sue to have that, to continue that privilege.
Well, they use it for recruiting, but I am kind of into this because I'm a General Mills retiree.
Well,
and then when you work for General Mills, like they have excellent health care. We have I have my own cardiologist when I had high cholesterol. It's right on site. We have a clinic, we have a fitness center, we have all these wellness programs and blah, blah, blah. And then they'll cover you on that insurance until you're 65 and you go on to Medicaid. But what they don't tell you then is they like to fire anyone who's sick. So they like a young, healthy population. That's part of how they keep their healthcare costs down.
That's another reason for universal coverage.
Yeah.
Is no more sneaky discrimination against sicker people or older people.
Yeah, like if you smoke, they might not hire you.
Yep, yep. So, it just,
DUI, they're not gonna hire you.
so that's, I just want you to be aware of that, but this is, and this is readable, right? You can read that, you understand that. Now I want to come to this definition of institutional and non-institutional providers. And when we start talking about this issue about how to deal with for-profit providers, those of you who followed this debate for a while probably know that HR 676 has long had a provision in it that says for-profit providers will have to convert to nonprofit status. I never thought much about it. I just thought, okay, that's a good idea. Profit's a problem. But now that I've started to look at the issue, I have 1,000 questions, and I'm totally up in the air. And if any of you have any bright ideas, I'm going to throw the questions out to you today, and I want you all to start to think about it. All right, so here is the language in John Martin's current bill, Senate File 1125. An institutional provider means an inpatient hospital, nursing home, et cetera, and I've highlighted that provides overnight care. Now, I don't know where John got that idea, because I sat and helped him write the current version of the bill back in '07. I don't recall having that discussion. I'm glad he did that, because I think we have to be fairly precise about what kinds of entities we want to be budgeted, as opposed to be paying a fee for service. And then he says a non-institutional provider means individual providers, and he makes a point of listing some entities, including imaging centers, that I suspect that Bernie's bill and Jayapal want to give budgets to. And I know this is going to be a little confusing, but bear with me because I'm confused about this. And here's how John's bill would pay non-institutional providers. It's a very simple. That's Section B. They will pay doctors based on rates negotiated with providers. Now notice that that's very different from Bernie's bill. Bernie's bill says they're going to be paid Medicare rates. I think this is better language. We want the single payer board to negotiate with individual healthcare, the representatives of healthcare professionals. I'm a little reluctant to try to stare into a crystal ball and say, we think come 2025, Minnesota docs should be paid 112% of Medicare rates. This just makes more sense, to me anyway. And then John's bill says payments to institutional providers shall be by annual budgets. They'll be split into an operating and a capital budget. And this is a new provision. This last sentence is a sentence that the Minnesota chapter of PNHP recommended to John about 4 years ago. We're so concerned about the merger madness in our healthcare system. We've got hospital chains in this country that are 100 hospitals long. Alina's got, what, 14? I think Mayo's got 14 or 15. That's the name of the game, to get big. And our concern was, at the time I was on the Minnesota PNHP board, our concern was that if we didn't say specifically in the single payer bill, you're not single payer board, you're not going to set a budget for a 14 hospital chain. Because you lose local control. And you're all aware that Mayo decided totally on its own to close down the OBGYN, the baby delivery services in the Albert Lee Hospital. Some CEO in Rochester made that decision. And you know darn well the Albert Lee people have no input on that. That is, one of the advantages of a single payer system is we get control over the allocation of capital and where services will be. And hospital shortages are becoming a more and more serious problem, particularly in rural Minnesota. So John, at our suggestion, thought, yeah, that's a good idea, and you see the prescription here. The single payer board shall set budgets for individual hospitals. We have 140 hospitals here in Minnesota. We'll have 140 budgets, not one for Mayo, one for Alina, etc. That prescription is not in HR 676 or Pramilla's bill. And none of those federal bills actually define what an institutional provider is. There's nothing that says it consists of nursing homes, hospitals, and hospices because they provide overnight care. I think it'd be a good idea to say something like that. Here you see the old definition of institutional provider. It just says, it uses the term institutional provider, and then says, such as, blah, 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 about a half dozen things. I, for one, don't know why you would want to pay a dialysis center a budget. I think you all know the argument for hospital budgets, right? They provide so many services that you don't want nurses keeping a price tag on every bandage, on every drug. I've actually seen pictures, I don't know, Ann, if this is how it works, but where nurses are walking around there keeping price tags on their uniforms so that when they get to the computer, they can enter in all of this stuff. And hospitals provide myriad services. It just makes more sense to treat them like a library or a fire department and not pay for all that data collection. Now, is that true for a dialysis center? I don't think it is. But I'm not an expert on how many services a dialysis center pays, has to keep track of. So I question why we don't have a tighter definition of an institutional provider. That was HR 676. And here is Pramilla's bills. Her definition of how we're going to pay institutional providers is we're going to give them a budget. But again, you see a slightly different list of entities. What's in here? Dialysis facilities. Yes, now that's in here, whereas in HR 676 it wasn't. Well, who decided to add dialysis facilities to the list of entities that get budgets? I'd like to know that. Here is Pramilla's bill on paying individual providers. She's saying, and you see, she doesn't use the word individual. She says a provider not described in section 611A. Well, we just looked at that. Here's section 611A. It's this motley collection of institutional providers. And so she says, if you're not one of those, then you're going to be paid on a national fee schedule. And look at the red words down there at the bottom. In setting this uniform national fee schedule, the Secretary of HHS shall take into account the amounts paid under Title 18, that's the Medicare law. So it's fairly flexible instruction, right? She's not saying what Bernie says, which is you have to get down to Medicare's level. Same with hospitals. She uses slightly different language about how to pay hospitals. The Secretary shall use existing, this is the purpose. Medicare pays hospitals now with something called diagnosis-related groups. So if you have a hip fracture, heart attack, there are about 500 of these, and so they're paying hospitals now on a per episode basis. And this section from Pramilla's bill simply says that when the Secretary starts negotiating budgets with the nation's 5,500 hospitals, he or she shall use current Medicare payment as a comparative payment rate. Now, you know, you can make as much sense of that as I can. They're basically saying, use your judgment, we'll figure this out as we go. And I think that makes sense. One of the great things about Pramilla's bill is that it repeals a whole bunch of junky programs that are called pay-for-performance or value-based payment. Now that's jargon, I think, to a lot of people. I hope I have time to explain some of that to you. In particular, she says we are repealing the Medicare Shared Savings Program. That's the name of the ACO program in Medicare. There are now about 1,000 ACOs in this country trying to become their own little HMOs. It's just another layer of insurance company. They have not proven themselves. And I really want to take some time to talk to you about this hospital readmissions reduction program. That's another program that's been inflicted upon Medicare by Congress. They're punishing hospitals if their 30-day readmission rate is above the national average. And it made no sense when it was enacted because there was no evidence that hospitals really have control over most of the important factors that bring sick people back to the hospital within 30 days after discharge. Yes?
Would you just tell, what's an ACO?
It's an accountable care organization. And it drives me nuts trying to explain it to people. But I'm hoping we'll have some time here. you can think about it, someone has described it as HMOs in drag. That's as good a definition as any. And to bless her heart, Pramila also explicitly prohibits HMOs and ACOs. She does it by saying you can't qualify as a provider if you don't give services directly to individuals. And so we've got too many people have gotten in the habit of referring to health partners as a provider. No, you're not. You're an insurance company, doctors and nurses provide, not you. And again, we were worried that she was going to endorse ACOs. This was such a treat to read this bill and see this provision and to see that she explicitly repealed the ACO provision. Now I want to come to a tough issue.
Can I ask one question before
Yes.
you pass that other subject?
Sure.
I thought that regulation or rule that hospitals would be fined, I thought that came with that living at home or remain in your home, because that's how they implemented it in the state of Minnesota, that they placed people in the hospitals to check out people when they left, to make sure that they had everything they needed when they got home, so that they would not come back to the hospital. So I'm surprised that it was a federal thing. Because Governor Dayton put that into effect.
I'm not familiar with what that is, but what I think she's asking about is, didn't we, in Minnesota at least, attempt to do a better job at the point at which patients are discharged to make sure they understand what drugs they're supposed to take?
Yeah.
And some hospitals are actually calling people up.
Right.
Congestive heart failure patients are getting called and they're being asked, can you breathe? Are your feet swelling? And that is helping minimize reductions. But the problem is that that's nowhere near enough to control readmissions within 30. I mean, 30 days is an arbitrary time. They could have picked 90, they could have picked 60. They picked 30. And it turns out that even though hospitals are trying to do precisely what you're talking about, they have been unable to reduce the 30-day readmission rate. And guess which hospitals are being penalized? It's the safety net hospitals. It's HCMC. It's the hospitals in poor rural areas and in inner cities. Why? Because they are treating people who have much less support at home, who, because of their life circumstances, are less likely to survive a heart attack or pneumonia or whatever it was they were discharged for. So we've gotten the worst of all worlds from this hospital readmissions reduction program. We're starting to kill people, and I've brought some research with me that's been published in the last year, and particularly the sicker people, because hospitals now have an incentive to try to keep you out for at least the 31st day, and then we don't have to report to CMS that you were a readmission.